everyone, and thank you for joining the Match Coalition 2021 Virtual Hill Briefing, Combating Maternal Mortality in the Age of Digital Health. It is my honor to introduce today's moderator, David Gray. David?
Hello, everyone. Hope you can all see me and hear me. I'm going to go ahead and get us started. Thank you so much for joining. Good afternoon, everyone, and I guess still good morning to everyone not on the East Coast. Thank you so much for joining us today for our very timely and important conversation, Combating Maternal Mortality in the Age of Digital Health. In the US, nearly 70,000 women are injured or die each year due to pregnancy-related complications. Studies have time and again shown the clinical benefits of technology in supporting pregnant women and their maternal healthcare teams to prevent such tragedies. And as we hear today, there is a lot of activity already taking place to address this, but even more work will need to be done. My name is David Gray. I'm the Director of Government Relations and Connected Health Policy at HIMSS, and I'm very honored to serve as one of the co-chairs of the Maternal Applications of Technology for Community Health, or MATCH Coalition, the host of today's briefing. Before we begin, I just want to go over a few housekeeping items. Today's briefing is being recorded, so if anyone has any colleagues that couldn't join today, we'll be sure to circulate the recording of this briefing far and wide. We do hope to have time at the end for questions, so we encourage everyone to take advantage of the Q&A function. When you do submit a question, please include your name and organization or office. If we can't get to your question live, we will do our best to follow up with any answers to any outstanding questions. The MATCH Coalition is a leading advisor on the topic of digital health for improving healthcare conditions and outcomes for pregnant women. Our membership is composed of a diverse group of stakeholders from across the health and life sciences community and is free and open to all who support the mission and objectives of the coalition. If you'd like to learn more about MATCH or find ways to get involved, I strongly urge you to visit the website matchcoalition.us. The primary goal of MATCH is to promote policies, guidelines, and regulations that support the adoption and application of clinically appropriate technology for the betterment of maternal health outcomes by fostering activities in the areas of research, education, and innovation. Today's conversation hopes to do just that by addressing a range of issues impacting the maternal mortality crisis in our country. We have an impressive group of speakers for you today, leaders in their fields representing patients, providers, policymakers, and technology manufacturers, to really bring together the key voices that will be needed to tackle this critical issue. Just a quick rundown of our agenda today. We're going to start the event with a spotlight conversation between Fran Ayasamayajala and Ms. Wanda Irving, followed by a fireside chat between Dr. Veronica Gillespie Bell and Senator Bill Cassidy, and finish off with an expert panel discussion. Before I turn it over to Fran and Ms. Irving, we wanted to play for you all a short clip.
I hope you never have to read this letter. I cannot imagine you having to go through this yet again. And if you are, I am so truly sorry, Mommy. I hope you know how much I love you and how much you mean to me. I am sorry that I have left you. On the particular day that I am writing this, I have no idea how that may have occurred, but know that I would never choose to leave you. You will forever be my mommy, and I your baby girl. Shalon was my only daughter. She was loving, she was kind, she was generous. She was just always a curious child and loved to learn. She graduated from high school after skipping 2 grades. She went on to get her bachelor's at Hampton University. From there, she got a master's of science and then was accepted into a PhD program at Purdue University. She graduated with a dual PhD in both sociology and in gerontology, and she was the first student to do that at Purdue University. Both degrees were summa cum laude, and all by the age of 25. She went on to public health because she had watched her brother, who was battling MS, so she decided she'd go and get a Master's of Public Health from Johns Hopkins, and then went on to become a well-respected epidemiologist at the Center for Disease Control. Unfortunately, her brother passed away, but she still devoted the work that she did at the CDC to her brother. Shalon was a very adventurous spirit, and we had traveled to over 20 countries in the last 5 years. She just loved life. When Shalon found out that she was pregnant, she was just overjoyed. She had wanted to be a mother for so long. She went to every single OB appointment. She did everything her obstetrician required of her. She had fibroids removed probably a year before the pregnancy. And then she found out at the time that she had factor V Leiden. So she also had to take 2 painful shots every day to keep from clotting while she was carrying her baby. Well, based on her history, her medical team thought it was best that she have a planned C-section. She was prepared, she was ready, and she couldn't wait to meet the tiny human that she'd been sharing space with for 37 weeks. Shalon had tears in her eyes. She was so excited to see her daughter, and Shalon just held her. Within 4 or 5 days after getting home, she developed a lump on her side. She started having other symptoms as well, headaches. She wasn't voiding as she should have been. Her legs started to swell. She started to gain weight. She had headaches. And every time we'd go in to see a doctor, she was just dismissed with, "You just had a baby, give it time. It'll get better." And she says, "Mom, I don't feel right. There's something wrong." And I was just so concerned, but I didn't know what to do. During the last week of her life, Shalon went to the doctor 3 times for the same symptoms. On that last visit, she presented with blood pressure of 174 over 120. "Well, let me give you some blood pressure medicine and you go home and come back in a couple of days if it hasn't gotten better. But don't worry, it should be fine. Just give it a little more time." Well, after we left the doctor's office, we went and picked up her prescription and we came home. And so we were sitting there talking a little bit more, and all of a sudden she started to have this gargled sound that came out of her mouth, and her arm shot up and she passed out. And I called 911. Probably 5 or 6 minutes later, the ambulance was there. When I got to the hospital, the emergency doctor told me that she was in pretty bad shape. I found out a couple of days later that she was brain dead because of the lack of oxygen. My cousin brought in a medical directive that I didn't even know Shalon had. And it said, "Mommy, I will fight hard, but if there is no hope, please let me go." And the next night, I happened to notice just one tear. It seemed like that came out of one eye. And I knew then what I had to do. We had her taken off life support. At 9:14, she was gone. I lost my vibrant, beautiful, intelligent best friend and daughter because she wasn't heard. I knew Shalon was a high-risk pregnancy because of her age, but I never for a moment thought that she was at risk of dying because she was a Black woman.
I'd like to invite to the stage Ms. Wanda Irving.
One moment.
It's okay, take a moment, take a moment. I'll go ahead and make a quick introduction. So it's very difficult to comment after such a tragic story, and we'd like to commend you for being so brave to be able to tell that story. And I can imagine it's hard having to tell it over and over again, as so many people need to hear this message, and you being so brave, choosing to tell it again and again.
Hello. I'm sorry.
Oh, that's quite all right. Just take a moment. Ms. Irvin, it's such a tragic story. And we are so honored to have you here with us today and being willing, as I was mentioning, to share that story with us. Why don't we just begin, if we could please, by you telling us a little bit about yourself and a little bit about the Dr. Shalon Maternal Action Project.
I'm sorry.
It's okay.
Yes, I semi-retired from nonprofit management in 2015 so that I'd have plenty of time to spend with my daughter and travel as we love to do. So I moved to Atlanta at that time so that we could be together. And of course, like I said, we traveled a lot, and we were just so excited about the baby cubby. And I decided then that it would probably be time to retire. So after I lost her in 2017, I fully retired. It took me 2 years to move from the denial stage to acceptance. And at that time, surrounded by a lot of her friends and her people from her village, I knew that at some point in my granddaughter's life, I was going to have to answer the question, what did you do, Grandma, to make sure that that didn't happen to anyone else? And so in talking to Shalon's friends, we decided to form a nonprofit organization that would, in fact, ensure that Black women knew the warning signs. They knew that they were more informed as to what was going on with Black maternal health, and that we provided the kind of evidence-based solutions that would in fact help them to have a healthy pregnancy and to thrive after birth and not die as a result of birth. So that is how Dr. Shalon's Maternal Action Project came about. Our mission is that we increase awareness of the Black maternal health crisis and develop evidence-based solutions that improve health conditions or health outcomes for Black birthing people and their families. And our ultimate goal for 10 years is to eliminate preventable deaths.
I absolutely love that. It's such an amazing and meaningful cause. But I would imagine that there, have been some discoveries along the way. Can you share a few of those with us? What have been some of the things that you and your organization have discovered along the way?
Well, I think there are quite a few. But the first thing that comes to mind is the fact of the sheer magnitude of the maternal mortality issue. That so many women die each year and don't have to. It surprised me that the United States was the country with the worst track record for maternal mortality rates. And that was just shocking in such a highly industrialized country that we allow women to die unnecessarily. It's like a silent killer of women that just has gone unattended to, I guess you'd say, for decades. And that was another surprising fact. This is no new phenomenon. This has been going on and on. And I just thought of the thousands and thousands of women that we've lost, and then the trajectory of the life of the kids that are left behind to suffer. And that was just totally surprising to me. I guess being a little south of 70, I wasn't really as informed or up to date on a lot of the statistics as I guess I should have been. And just to find that out and know that there are things that could be done and they're not being done, that is, I guess, what energized us to doing something as far as forming our organization. And then I know Shalon was the kind of person that she didn't like to do data for just data's sake, I mean, she was just a phenomenal researcher, but she believed heavily in community participation in her research. She believed that research shouldn't sit on the shelf. And to me, it seemed like there had been years and years and years of data collection, but to what avail? Women were still dying at such a high, appalling rate, and nothing was being done to take that research, that data, and put it into action.
I think that's a very, very valid point. There has been so much data that has been collected and unfortunately gone underutilized. Today's conference briefing, if you will, is on the topic of the application of digital technologies for the prevention of maternal health. Mm-hmm. And over the years, and certainly now during the pandemic, we've seen the ability for technology to make a difference for many individuals. What is your perspective on the use of technology for maternal health?
I think if COVID has taught us anything, it's the power of social media, the power of digital technology. I think that in order to improve outcomes, as Shalon would say, you've got to meet the mothers where they are. You've got to get in their hands something that they're going to be able to use. So I think having telehealth and other digital kinds of opportunities is going to be what's going to move the needle forward. I know for Dr. Shalon's map, we've developed a peer empowerment app that we're going to be launching in April during Black Maternal Health Week. And that is evidence supported by the fact that peer support programs have been proven to be effective in improving both physical and mental health. And we had planned to do a lot of that in person, but as you said, COVID has changed the whole paradigm. So we are bringing it to the digital world, bringing it to women, because I don't know of any woman who doesn't have a smartphone. And they're just, that is one of the best ways, I think, to get technology in the hands of women and help them to help themselves with their pregnancy journey.
I love it. Thank you for recognizing the value that it can have. Just in closing, I mean, this meeting is bringing together many folks across industry, right? Everyone, legislators, so politicians, manufacturers, care providers. But at the end of the day, we're all mothers, daughters, fathers, and sons, right? Can you leave us with a message? If there were something that you'd like to instill in the minds of everyone who is participating in this event today, what would that be?
I think what I would like to say is that every single person has a circle of influence. It is incumbent upon each and every one of us to make sure that we do whatever we can to change the paradigm. Shalon used to always say, I see inequity wherever it exists. I'm not afraid to call it by name, and I work hard to eliminate it. I vow to create a better earth. I would ask everyone to vow to create a better earth and do what you can to eliminate inequity in your circle of influence.
Ms. Irving, thank you so much for being with us today. We are going to actually invite you to join us again during the panel discussion a little bit later. But for now, we say thank you and we appreciate your time.
Thank you.
David, back to you.
Yeah, thank you, Fran and Ms. Irving, for that really powerful conversation. We really do look forward to having you back as part of the panel. As we wait for Senator Cassie to join us, I'd like to welcome Dr. Veronica Gillespie Bell to jump on the camera, who will be giving an overview of the maternal health landscape in the U.S. before leading the fireside chat. Here she is. Dr. Gillespie Bell is an obstetrician and gynecologist at Ochsner Health System, and among the many different hats that she wears, Dr. Gillespie Bell serves as the Senior Site Lead and Section Head of Obstetrics and Gynecology at Ochsner-Kenner, the Director of Quality for Women's Services for Ochsner Health System, and is the Medical Director of the Louisiana Perinatal Quality Collaborative and Pregnancy-Associated Mortality Review for the Louisiana Department of Health. Dr. Gillespie Bell, thank you so much for joining us today.
Thank you so much, David. I want to start with saying first a thank you to Ms. Irving for sharing Dr. Irving's story with us. I am humbled to share the stage with you, and I am ashamed that we were not better for Dr. Irving. And to the audience, you've heard the statistics. I would love to sit here and tell you that Dr. Irving's story is the only one that you will hear like that, but that's just not the case. As you heard David say, 1 in 700 women in the United States of America will experience a pregnancy-associated mortality. And we know about that not only are we having deaths, but we're having disparities. 3 to 4 Black women die at a rate of every 1 white woman. We have at the worst maternal mortality rate in the United States compared to other developed countries. And yet we're a country that spends 17% of our gross domestic product on our healthcare system. Now, all of this is very tragic to hear, but I also hear opportunity. We can do better, we can be better. And I'm happy to be here with you today to discuss my experience with telehealth and what it's done for my patients and what I have seen the advantages of telehealth in improving some of these outcomes. As David mentioned, I'm the medical director of the Louisiana Perinatal Quality Collaborative, and I can tell you that across the United States, perinatal quality collaboratives have been instrumental in making sure hospitals and birthing facilities have ensured readiness for those clinical causes that we know increase maternal mortality, the 2 leading causes being hemorrhage and hypertension being the leading cause. Those collaboratives are working with those birthing facilities, again, putting in readiness and response so that we can respond better. But I also know that from reviewing our maternal deaths in Louisiana, our 2017 deaths, that over half of the patients that had a pregnancy-related death, meaning they had a condition that was related to the pregnancy that caused their death, over half of those individuals were outside of the hospital. They experienced their mortality up to 42 days after delivery. So we have to think about what can we do to help connect our birthing persons back to the facility. We think about pregnancy as that time that we deliver the baby, and then we send moms home to be alone for 6 weeks, not connected to the healthcare system. And because we're looking at data, we know that that is a very, very vulnerable time, especially in terms of severe maternal morbidity and in mortality. And I also think that we are in 2021 and our antiquated way of delivering healthcare has to be changed. We have built a healthcare system that's designed around the healthcare system. It's not designed around our patients. We're at a time that we have to begin meeting our patients where they are. And telehealth has a way to do that. It has a way to meet our patients that don't have the ability to come in to see us for appointments. It has a way of meeting those patients that are in rural areas that don't have the ability to, the time and the resource to come in to see providers. And furthermore, telehealth gives our patients a way to empower themselves to be able to take control of their health and to be self-advocates for their health when they see these outcomes. And so again, I'm happy today to be able to be here with you and share my experiences with telehealth and what I have seen. I have been participating in our telehealth system here over the last 6 years, and we have seen some tremendous improvement in being able to diagnose severe hypertension and being able to act on it early. And again, for our patients to be able to understand those components and those vital signs and what that means for their outcomes so that they can be advocates for themselves. I'm excited that we have so many individuals that are here today from legislators to clinicians to technology to just others that are here with interest. I'm so excited that we're here because I really believe that all of us coming together is the way to start improving maternal outcomes. Not only improving outcomes, thinking about our statistics, but improving our health disparities so that we have equity and so that we're able to overcome some of those social determinants of health and some of the biases that are responsible for the reasons that we see some of these disparities. And so just happy to be here with you today to share more about that.
Thanks, Dr. Gillespie Bell. We're still waiting for the senator to join us, but we do have a question that just popped up. It says, can you please answer why Louisiana analyzing deaths up to 42 days postpartum instead of the 1 year postpartum? The CDC says 24% of maternal deaths occur between 43 days and 1 year. Most MMRCs across the country are using that 1 year postpartum definition.
Sure, so I can answer that. So we actually do participate in the CDC MMRC, and we do analyze our deaths up to 1 year postpartum. I'm not sure if you're looking at the report that was done analyzing deaths from 2011 to 2016, where they used the WHO definition of maternal mortality, only looking at pregnancy-related deaths up to 42 days. Since that time, and that was a desire to be able to analyze data quickly because we had not had a maternal mortality report since 2008 in Louisiana. But since that time, we do now have a pregnancy-associated mortality review committee that's multidisciplinary. And we review maternal deaths from all causes, not just pregnancy related. And we do review up to 1 year after the termination of pregnancy.
Thank you so much. And it actually does look like we have Senator Cassidy on the line. So would you mind jumping on video while I give you a quick introduction?
It says I can't because my host has stopped my video.
Well, we'll figure that out while I just give you a quick introduction. For those who do not know, although I'm sure not many of you on here don't know, Senator Cassidy is the U.S. Senator for the state of Louisiana. A gastroenterologist by training, he received his MD from LSU School of Medicine. He was first elected to the Louisiana State Senate in 2006. In 2008, he was elected to the U.S. House of Representatives, representing Louisiana's 6th congressional district. And in 2014, he was elected to the United States Senate. Senator Cassidy serves on the Senate Finance Committee, the Health, Education, Labor, and Pensions, or HELP Committee, the Energy and Natural Resources Committee, and the Veteran Affairs Committee. Senator Cassidy, thank you so much for joining us. And Dr. Bell, I will turn it back over to you.
Got it, I'm on. Oh my gosh.
Hi, Senator Cassidy. Good afternoon.
Hey, thanks for having me. What a great St. Patrick's Day dress. My tie is green, but it's hard to see, but no one can doubt that you're in the spirit.
Thank you, thank you, thank you. I was sharing with the group the benefits that I've seen for telehealth and improving maternal outcomes, and I know that you share that same sentiment. And so could you tell us more about the Connected Mom Act?
Yeah, Dr. Bell, I learned from you, so you should be telling the story. It would allow government programs to pay for remote monitoring of a mom. And the background of it, in terms of my interest, aside from you telling me that it works, is my medical practice in Louisiana was in the charity hospital system. And so for any patient, but imagine a mom who is 8.5 months pregnant, who has to take public transportation in August to her appointment. And public transportation in New Orleans works pretty well. In Baton Rouge, sometimes not so much. Just imagine that difficulty. And then as well, as a liver doctor, and you'll know this, there are a set of conditions associated with preeclampsia called the HELP syndrome, which tends to occur in women in their last trimester who are pregnant. I would see those patients. They would call in the liver doctor to come look at them. And so I had the evidence, I had the intuition, and so this just seems so perfect. If a mother at risk of preeclampsia could be monitored at home remotely, how much easier would it be for her care to be delivered, monitored, if need be, send an ambulance, as opposed to sitting out in a Louisiana August, waiting for that bus to come. Where is it? I hope I don't miss my connection. That was kind of the whole genesis of it.
Yes, and thank you for that. And definitely being an OB in Louisiana, and having some oversight over the birthing facilities across Louisiana, I think those are all great points, and that is the reality of care. I think it's also important to note that Louisiana is a state that is considered to be very rural and we have a lot of rural areas. In fact, based on the previous census, we only have 3 parishes. And for those on the call, in Louisiana, we use parishes instead of counties, but we only have 3 parishes that had greater than 250,000 individuals in them. And so, yeah, definitely in our rural areas, it can be difficult to receive the same prenatal care. And what a great way to have moms to be able to stay in their own community, and still be able to get that adequate care by being connected to their provider through these different telehealth systems.
One thing we also know, and now speaking as an internist, is that your blood pressure may go up just because you're dadgum stressed. And so again, imagine that you're close to term and you're having to go through a stressful place to get there, a stressful place to navigate the hospital. Sometimes life just breaks that way. So how much better to have somebody at home, at rest, being monitored. Now, by the way, in our bill, you can also measure heart rate. You can measure whether or not there's protein spilling in the urine. So that information can be sent remotely. All the things that you'd want to know for a mom who might be at risk just before she delivers, not all the things, but some key things, it can be transmitted remotely. I always like to apply the golden rule. Would I want my wife or daughter to have access to this when she was 8.5 months pregnant? And the answer is absolutely. So can we make it available for others who may not have the same resources or transportation that those in my family do?
Yes, thank you. And great points. And I can tell you anecdotally, as someone that has used our telehealth system over the last 6 years, I have patients that I have been able to diagnose with preeclampsia with severe features in between the times that they would have been coming into the office. I'm thinking of a patient in particular that was diagnosed at 31 weeks. And typically with our schedule of visits, the patient would be in the office at 30 weeks and 32 weeks. And so through our program, I got a notification, the patient got a notification that her blood pressure was elevated and that she needed to get to the hospital. And she did indeed have preeclampsia with severe features. We were able to respond to those blood pressures quickly, gave her the appropriate medication, magnesium sulfate, to prevent seizures, and she delivered a healthy baby girl, premature, but at that time delivery was the right option. And so mom and baby both did well. And that story may have been different if she had just been sitting at home without these resources.
Yes. And think about that. One of the big things we have to worry about is the how do you pay for it, right? But just think about how early intervention potentially saved a C-section or an ICU stay or a NICU stay. There really is a promise here of delivering better care, which at least could partially offset some of this expense, aside from the fact that maybe she does not have to come in as often because she's being remotely monitored.
Yes, agreed. And one other thing I think I would like to point out to the audience, and Senator Cassidy, I know you're already aware from conversations that we've had. I can give anecdotal experience, but I wanted to see what the data showed. I knew, like I said, anecdotally that this telehealth system would improve outcomes, but I wanted to see what the data showed. And in fact, when my team and I looked at our moms who had hypertensive disorders, whether that be chronic hypertension, gestational hypertension, preeclampsia, that those moms that were in the telehealth program versus moms in traditional care, those moms that were in the telehealth program got that life-saving blood pressure check within 7 days of discharge from the hospital. so that we are again able to act on those blood pressures when they were elevated. As a mother, now my son is 8, so this is a while ago, but as a mother, to think about being from the hospital 1 week after delivery and having to come back to the hospital just to get my blood pressure checked, that's a daunting task. And so I think that we've been able to prove that having that telehealth system and being able to have that remote monitoring, not only is it safe, but it also improves compliance with care. It starts to overcome some of those obstacles that you were speaking of.
And again, if you're speaking of folks who are lower income with more transportation challenges, or if you're speaking about a practice, because oftentimes, practices can be just stuffed to the gills. It is a way that you're doing true monitoring to benefit the practice, but to disproportionately benefit those people with transportation challenges. Those tend to be lower income. As we know, maternal mortality knows no financial kind of limit, right? But that said, people who are African American or who are lower income are at increased risk. And so this is a program which I think could bring particularly benefit, recognizing that particular challenge.
Yes, 100% I agree. And for those on the call too, with the program that Senator Cassidy is speaking of, those individuals are able to get a blood pressure monitoring device that uploads directly to the electronic health record through their smartphone. We know from looking at data that almost everyone has a smartphone and has that technology. So blood pressure cuffs, also scales, and as you mentioned, Senator Cassidy, also the ability to do a urine dipstick to look for protein.
Veronica, can I ask you just a favor for a second?
Sure.
I gotta go vote. Can I come right back? I'll be back in 4 minutes, 5 minutes.
Sure, go ahead and do that.
Hold the fort. I'll be right back.
I will fill the space.
Well, this is exciting, right on the fly here. We've got a question from our audience for you, Dr. Gillespie. And one of the questions asked is around the use of telehealth services over the COVID-19 pandemic. What are some of the odds that the telehealth waivers might be used? But could you tell us, before we have the senator come back and maybe talk to that, could you tell us a little bit about how you've seen the increased use of telehealth for maternal health purposes?
Oh, yes. So I often talk about this, that here in New Orleans, March 13th was when I was at my son's school, and that's when they said we were shutting down. Pandemic is here. We're shutting down everything. By Monday, when I was in clinic again, I had switched all of my patients to virtual visits. I was able to do that because of telehealth. So for my moms that were enrolled in Connected Mom, they had their blood pressure cuff at home. They had their digital scales. I was able to see those vital signs. And then we have a component in the electronic health record that would allow me to do almost like FaceTime, but similar to what we're doing today, where I was able to have a virtual visit where I could actually see my patient. And so it really, really, really was crucial in not interrupting care, because we already had a telehealth system built in. And when we looked at our patients and polled them as far as satisfaction, they really were satisfied with the ability to get care in that way. One, their service was not interrupted, and they felt protected because they were not having to come into the hospital system. Now, let me be clear that telehealth cannot replace every single visit that would happen, but it is definitely an adjunct to being able to deliver prenatal care. And again, as we mentioned, when we think about those patients, even outside the pandemic, that have difficulty getting to the provider, it does allow them the ability to stay connected without having to be in person. So we were positioned really, really well during the pandemic to be able to not have interruptions in care because of telehealth and having our telehealth system already in place.
That's really insightful information. I'm curious to know, In regards to the opportunity for collaboration across specialties, such as obstetricians, gynecologists, and pediatricians, as an example, one of our attendees has asked the question of how might we go about leveraging technologies, like taking blood pressure as an example, during those first wellness visits with at the pediatrician's office, but of the mom's blood pressure, right? What are your thoughts about that collaboration between the two?
Yeah, so actually, I have a pilot that we've done looking at that as well. When we look at postpartum visits, we know that only about 40% of patients actually go to their postpartum visit, but almost everybody goes to the newborn visit. And so we have worked with our pediatricians because they are seeing the moms to be able to do not only blood pressure checks, but also being able to do perinatal screening for depression. So that collaboration is hugely important. And I think, again, as we think about different ways to deliver care in 2021, we have to stop thinking about swimming in these individual lanes of I'm the obstetrician and I'm the pediatrician. And we really have to work on family-centered care where we're able to cross those disciplines.
Well, that's wonderful. Well, it looks as though Senator Cassidy is back again, and this is so exciting. It almost feels like a CNN. It's like live. I love this. Thank you, or a Fox News. Thank you so much. I'm going to now pass it back over to you to continue the fireside chat.
Thank you. Thank you. And so thank you, Senator Cassidy. Obviously, you have a very busy day, so we really appreciate the time that you've given us today. And thinking of all the stakeholders that you have here today, how can we as providers, as telehealth systems, as people that are interested in improving maternal outcomes, how can we help you?
So the name of the bill, I think it was on the chat, somebody asked and somebody gave it, the Connected Moms Act. Wherever you are, you can advocate with your congresswoman, congressman, or senator. And sometimes we think, oh, I'm just a person. No, if you advocate, it really brings it home. There's a lot of concern for maternal mortality. We in Louisiana have a higher, unfortunately, maternal mortality rate. But if you look at Hispanic women in Los Angeles, they got a very high incidence of diabetes and hypertension. And Dr. Bell, you can kind of quickly tell me the increased risk that gives them. I know that because I did my residency in Los Angeles. And again, as a liver doctor, would go see women who were just before delivery with the so-called HELP syndrome. And you look at the prevalence of diabetes and hypertension, and you know there's going to be complications there. So I pick Los Angeles because I have personal experience. Pick any community in the United States, you're similarly going to come up with such a profile. So what we need folks in this audience to do is to make an appointment with the congresswoman, congressman, or senator who represents you. Go advocate for this bill. Again, Connected Moms Act. Maggie Hassan is a Democratic senator from New Hampshire. And obviously I'm the Republican from Louisiana, so it's bipartisan. I'm forgetting who the members of Congress are, the representatives, but my staff may put that up on the chat. But again, it'll be bipartisan. But whoever your person is, make an appointment. You may not meet with them directly, but you can meet with them with their aide who will pass it on. And give them the Connected Moms Act. Ask them to co-sponsor. See if they will get on board. This is like mom and apple pie, literally, right? It's taking care of mom so she can make the apple pie. And if you do that, it's more likely to pass. That's what we need. We need your support.
Awesome. Thank you for that. Thank you for that. And as you said, we all have a part to play and can see this act through. And again, I've seen the benefit in my patients. We've seen the benefit in looking at those at the studies. But we do know that every facility doesn't have the finances to be able to get the equipment, and so this act I think can be huge in getting those things done. And then Senator Cassidy, there are some questions for you in the chat box. Someone wanted to know if the Connected Mom Act will extend through the year after the delivery of the mom.
Right now, this is for telehealth that would manage. To your point, we do know that some problems persist. And so, but right now, and let me sort of, this is particularly for Medicaid policy for people who are prepartum. But we know that these same technologies can be used for other conditions. And this is part of a broader push that we are making to expand telehealth or in telemental health. So this bill in particular is focused on prepartum, but we are working in other legislation to expand it in the postpartum. So if there is someone who is a diabetic, perhaps has diabetes related to her pregnancy, we could continue that monitoring afterwards. And similarly for hypertensives. One of the concerns that my Democratic colleagues have is that this will become an avenue for fraud. Oh, yes, you're telemonitoring. No, you're really not, but you're billing for it. The degree to which this technology substitutes for the doctor's visit, as opposed to just is added on top, if you will, is at worst cost neutral, is I think the degree to which it's adopted. So we do have some things to work out. I'm giving a long answer to a straightforward question. We do have some things to work out to make it more broadly used, but I'm optimistic that we can do that.
Yes, and to your point, we have our Connected Mom program at Ochsner Health, but it really started with digital hypertension and digital diabetes, and seeing in the general population how much better controlled those blood pressures were for those patients that were enrolled in the digital hypertension program. And out of that is where Connected Mom came from. And really the possibilities are endless when we look at managing chronic illnesses. And as you mentioned, we know that, and ACOG has information on this, that for women that have preeclampsia with severe features or preeclampsia at all, have a 3 to 4 time risk of having lifelong cardiovascular disease and then going on to have chronic hypertension. And so getting them plugged into the system early is really huge with in improving their overall lifetime outcomes as well.
Mm-hmm. Absolutely. Absolutely. Yeah. If you can make an impact on chronic renal failure, if you can just save one case of hemodialysis because you've had better monitoring of hypertension and diabetes, every healthcare provider on this panel understands the incredible improvement in outcomes. Somebody's going to live a better life. They're going to pay more taxes because they're more likely to work. And by the way, we'll save a heck of a lot of money on medical intervention. So I do think the potential here is quite remarkable.
Yes, I agree. And Senator Cassidy, thank you so much for your time today. And again, if there's anything that I personally can do to help you, please let me know. We really appreciate all that you're doing to give a voice to moms so that we can see better outcomes.
Let me thank everybody on this call. I will emphasize once more, this is more likely to pass if you, the advocates, are engaged. And this is about moms, which gives it a real kind of appeal. And if y'all want to have a later talk about how to go and approach an office, just practice, make sure it's 15 minutes long, make sure you hit your most important part, and leave them something when you leave. Give them something when you leave that they can review and share with their boss. But there's and all you have to say, this is the problem of maternal mortality. These are the conditions that lead to that problem. This is how this addresses the problem. We think it'll work because it's consistent with other things that have worked. We ask you to support the Connected Moms bill. If you folks can do that, it's more likely to pass. This is a partnership. I thank you for your partnership. And Dr. Bell, wonderful to see you.
It's good to see you as well. Thank you so much.
Yes, ma'am. Thank you.
And back over to David.
Yeah, thank you so much for that fascinating conversation. You know, I think, or at least I hope I speak on behalf of everyone here by saying how motivated I am to get some real change enacted, including seeing the Connected Mom Act signed into law. Moving right along, I'd like to bring back Fran to introduce the panelists and get that panel conversation started.
Thank you so much, David. What a wonderful session between Dr. Gillespie Bell and Senator Cassidy. It's now a great honor to be able to introduce our panel for today. Dr. Rebecca Rick, who is an obstetrician gynecologist from the University of Virginia Health. Veronica Adamson, who is the general manager for obstetrics monitoring at Philips. Wanda Irving, founder of Dr. Shalom's Maternal Action Project. And Tanya Wu from the office of Representative Eddie Bernice Johnson, Democrat from the state of Texas. Ladies, welcome to the panel. If you will, please turn your cameras on and unmute your lines. This has been such an amazing morning so far. Have you guys enjoyed it?
It's been fantastic. It's moved me from, tears of joy to just tears. So it's been a very moving session already.
Indeed, it has been. And, there have been so many things thus far that have been covered. I'm going to take us back for a moment and maybe talk and ask us to talk a little bit about the clinical side. Dr. Gillespie Bell did an awesome job earlier, kind of setting up the stage in terms of this, the need to have a sense of urgency around this particular issue. We know that every year there are, well over 700 women who unfortunately lose their lives as a result of complications during pregnancy. And there's another 70,000 who experience some form of injury as a result of complications or something that occurs during the process of childbirth. Dr. Rick, I'm going to bring it to you for a moment. Can you talk to us a little bit about some of the changes and best practices that you're seeing within clinic and what you'd like to see moving forward?
One of the things I've really enjoyed seeing is we've gone from having telehealth options like Dr. Gillespie Bell talked about earlier, being a presentation at our national meeting. I think it was 4 years ago, and they showed they reduced stroke rates, and now it's being widespread. Here at UVA, we have a program somewhat similar to hers as well, and I think that treating women where they are is becoming more and more, even prior to COVID, part of our routine, as well as aggressive treatment of blood pressure. It's quite a contrast and an ability to reduce those readmissions. Similarly, at the same time, I think something I have to acknowledge recently is our patients know that they're at risk and they bring it up. And I think that knowledge and us acknowledging that our health system does not necessarily treat everyone equally, that's an inherent boundary, is becoming more and more a part of our conversations every time we see patients. It's counseling patients about blood pressure, it's treating those blood pressures, and it's monitoring them after delivery is a big part. As we've transitioned into our telehealth, we used to bring patients in for a 1 week blood pressure check, and now by the time they hit their 1 week blood pressure check, I have 8 or 10 or more values to follow for blood pressure, which is really nice. And in those patients, they don't get readmitted, they don't come to the emergency department. And I think that for us has been the biggest part for me.
Excellent. And Veronica Adamson, tell us a little bit from the monitoring perspective of the technologies that your team is using that help to support clinicians like Dr. Rick in that process of better monitoring patients.
Yeah, thanks, Fran. And really grateful to be here today, by the way, and appreciate the opportunity to have this conversation and work together, really changing the future for moms and their families. So for me, I think there are 3 main problems that technology solves in this space today, or at least has the potential to solve. And it's really about empower. So the first is empowering expecting families with the communities and the information and the tools they need to back up their gut instinct. So when they feel like something is wrong, to have information at their fingertips and people to be able to act on it. And I think that is incredibly important, especially for the 10 million or so women who live in counties without a single OBGYN. And apps like, we have some, like you mentioned at Phillips, we have Pregnancy Plus or Baby Plus, but there are many others, like Ms. Irving mentioned, that can put that information in the hands of families. I think that's one of the first areas. The second that comes to mind is empowering clinicians to go beyond telehealth into maternal and fetal monitoring, so actually monitoring vital signs at home. And as Senator Cassidy and Dr. Gillespie mentioned, there are so many women, especially the 30% or so of women who are at risk that can't access care. They need to take a half day off work. They need to find childcare. They need to get transportation. And for those moms and families, bringing that technology into the home is something that we're seeing increasingly in the US. So bringing the fetal and maternal monitoring into the home. It's a common practice in Australia, in Europe. So that's another technology. And especially for those moms that can end up needing to go in 20 or more times during their pregnancy, and then afterwards, even more. The last thing, and then of course I'll turn it back to you, that I think is important is empowering moms to focus on their babies and not worry about being a statistic after they give birth. There are a lot of technologies that exist today to keep eyes on mom after birth, make sure that there aren't complications. And one of the areas that I find most exciting there, and of course, at Phillips that we work on as well, is bias blind software algorithms that can identify when moms are at risk in a passive way. So you can see it, before it happens. So those are the areas, that I see as the technologies that are addressing this. And of course, as you asked, at Phillips, we also have, of course, remote fetal and maternal monitoring solutions, in addition to the partners that we have, for example, Nuvo or Biorhythm or others that are also working in this space.
Thank you for that, Veronica. So for just a moment, I want to remind our audience to please put some questions into the chat window. We're going to make sure that there's some time for Q&A towards the latter part of this panel, and we love those questions to be coming in from you. I have to first of all just sort of react to what Veronica has said. For a moment, it kind of makes me say, wow, okay, so we want to empower, there's the opportunity to empower the woman, empower the family, empower the community, but you mentioned a lot of terms that for me, I get it, right? But for a lot of people, they don't get it. You're like, there's tools, suggested technologies that no one's ever heard of. Some people might say, what is an algorithm? And it just sort of makes me think, Ms. Irving, if you would jump in here, please, that perhaps there's more education, that it's hard to get someone to be engaged and to empower them if they don't know what's available to them. Would you mind commenting a little bit from your perspective, Ms. Irving, what your thoughts are on that?
I actually do believe that you're absolutely right. That has to be brought to the community of women that you're talking about. That education is highly important. And I guess I'm just having a little bit of trouble with some of the things that you've said as far as bias blind algorithms and some of the empowering of clinicians. Unless you get at the root cause of all of this, I don't know if that's going to really make a difference, because those bias blind algorithms are still being conducted by biased people, and they're still being put on to Black women. And I guess I'm just struggling with trying to connect the two dots, because the racism, the systemic racism at the core of all of this has to be addressed. These are really nice Band-Aid approaches, but until we address what is really causing the problems, I really don't see how, a lot of that is going to end maternal mortality. We say, oh, well, the healthcare system is broken. These are ways to fix it. but the healthcare system isn't broken. It's operating exactly as it was set up to do. And that's the problem. And that's what needs to be addressed. I mean, there needs to be a total paradigm shift before a lot of these things can actually work.
Some very good points being raised here. Tanya, it makes, this conversation is making me think to what legislation and policy can do. If you don't mind, start off by sharing with us a little bit about the work of your representative, the Save Moms Act, some of what you're seeing broadly as it pertains to the sort of the nuts and bolts of the Momnibus as well, please.
Yeah, no, thanks for having me for this very, very important discussion. Just for a bit of background, so my name is Tanya and I'm a legislative assistant for Congresswoman Eddie Bernice Johnson. She's the Democrat from the Texas 30th Congressional District. And so she is a member of the Black Maternal Health Caucus here in Congress, which is, it was formed last Congress to address a lot of the issues that have been brought up in terms of just the systematic issues that we need to address as a society when it comes to maternal morbidity and maternal mortality, especially for the Black community. And so specific to my boss, so it's as a bit of background, just if it's helpful. So my boss, she was actually the first registered nurse elected to Congress. And so because of her background, a lot of the interests, and she also chairs the House Science Committee. So the intersection of healthcare as well as technology and innovation is definitely something that she's very focused on, and our office definitely tries to be proactive in. And so we were very fortunate. My boss currently has a bill. It's HR 937 this Congress. It's the Tech to Save Moms Act. And just a bit of background, it makes federal investments to promote the integration and development of telehealth and digital tools to reduce maternal mortality and severe maternal morbidity. And there's also specific investments made to address racial and ethnic gaps in maternal health outcomes. And so we are very fortunate that this bill was included in the omnibus legislation that the Black Maternal Health Caucus has put together, which is wonderfully named as the Momnibus. So we're very hopeful that, this package legislation, or at least pieces within it, is able to move this Congress, because I think there's a very solid recognition up here, and not just a recognition, but a need for action to address disparities and to not just acknowledge them, but to actually put something into action, to actually do something about it. And so we're hopeful that, a lot of the work that members of Congress have done on this issue, we're able to see some light on it this Congress.
Very, very good points. And Veronica, yeah, please jump in for us. Mm-hmm.
Yeah, no, I think those are great points. And I think what Ms. Irving mentioned just now is also really important, just taking a step back in terms of looking at the overall problem and where the root causes are. And I think I just want to reiterate the point that technology is an enabler, but it certainly isn't going to be the solution in and of itself. At the end of the day, it's the providers, it's the families. That's where the real change is going to happen. I think technology is a way of supporting, but not solving the problem. I think that the positive news there is that we do see in certain countries where they've adopted the technology, the impact it's had. But it's one part of the bigger picture. So I think that was an important point. And I don't want to oversell technology, because it is a tool, right, at the end of the day. So it needs to be used, and it needs to be used wisely.
I appreciate that clarification, Veronica. I totally agree with you there.
Ms. Irving, I acknowledge what you say. I think over the last 5 years, and I think particularly your daughter's story, has brought to light the systemic racism and how it affects healthcare for African American women. I live in Charlottesville. It's a place where we are heavily aware of race and the various issues. I think we're working on some of these things. I think that for many of my patients, they live in rural areas. Virginia is a very rural state, similar to Louisiana. And being able to use some of these virtual technologies have given me the ability to give patients a degree of control over their own healthcare. And I think that helps a lot. I think the other piece is there isn't a quick fix. We acknowledge it. When I first arrived here, I had a patient who was a PhD dietitian, and she was terrified to be pregnant. She knew very well what her risks were. She was an African, and one of my partners acknowledged that our healthcare system has inherent racism, and we need to figure out how to work with that. And there's not a quick fix. I think acknowledging it and not just saying it's there, but acknowledging the different risks, and it's due to healthcare, it's due to not acknowledging those maternal complaints and telling, like, your daughter called every time. And that's what whenever patients call, we talk about having them come in or going to the emergency department and knowing those things. And it's not fast, but we're working on it, and that's the,
Okay.
sorry.
No, that's quite all right. And I think it's a very good point. We are working on it, right? We at least we can't sit and continue to be complacent. And that's what I think the biggest opportunity is. And Tanya, from that perspective, maybe if you could shed a little bit of light here, because I think that there's something that maybe is being unspoken, right, in the dynamic of this panel right now. And that is, while technology in and of itself is not a solution in it, right, on its own, it does put a spotlight on the data, the data in itself, beginning to capture that data, but the reporting has to take place. So can you talk to us a little bit about changes in the legislation as it pertains to ensuring that reporting is taking place, that we're not just capturing data every 7 to 10 years, so that we're able to really begin to make some of the quality changes that are necessary?
Yeah, I think to the point that you raised, I think it's a very broad issue when it comes to addressing a lot of the disparities. It's one, making sure that, these moms have access to coverage that's accessible and affordable, and then making sure that they can actually get to and from care, and that the care is culturally competent. But it's also like making sure that our health systems and the public health departments and all of the institutions that we have built up in this nation and in our health system to actually collect the data, that they're able to seek out the populations that we need to know more about, that we need to be able to interact with to actually counter these disparities. And I think there's a very solid recognition in or at least I can only speak to my member and to the work that she's been doing and to the committees that she sits on and the caucuses that she's worked with. But I think there's a very strong recognition that there is, system-wide, and in terms of just like all the federal programs that we run and all the bills that have been passed, like there needs to be a specific investment and call out to a lot of the disparities that are institutional. And I think it's decades and generations that built up. And I think unless there's a cognizant, proactive effort to acknowledge that and to fight to actually counter that, it would be hard to change sort of the outcomes that are very tragically still happening without, dedicated efforts to do so. I hope that answers the question, but I think
it does. It totally answers the question, and it actually complements a question that's coming in from our audience very well. And I'd love for anyone to jump in with some response on this one. The remark comes in as, I believe we need to ensure that we are offering technology that is simple to use and that covers both the needs of the moms pre and postpartum. What do you think is the biggest barrier to getting high-risk moms to use technology that we're making available and making sure they're able to access it?
I mean, I can speak to some of what we're seeing. I think one of the barriers is awareness, right? Do moms know that there is technology that they can use to, for example, stay at home instead of going in for their appointments? Do they have it available to them in their care? And then I think also, are they comfortable using it, right? And I think a lot of that comes back to really the care and the community that they're in. Whether it's something that is accepted And of course, whether it's something that's reimbursed, because the cost is, of course, another issue on both sides.
Anyone else care to comment?
You know, in our area, there's two barriers. It's the costs. Many insurances won't even cover the cost of a blood pressure cuff. I'm not even sure my own does. That is a big barrier. And the other barrier that is inherent to some areas is also the access to internet. There's still areas in my state, and I'm sure in Louisiana and other states, where there's no cell service, there's no broadband internet in wide swaths of where we get patients, and especially transfers of these high-risk moms. And that's the other big barrier that I see, is both coverage and providers to monitor this. It's a unique opportunity to develop good relationships with patients, but it takes time, and that is getting all three of those things together will probably help us a lot.
One perception is that pregnant women are healthy, right? This is a comment coming again in from one of our participants, that, you know, that it's often viewed that pregnant women are healthy, and that may not be the case. How do we change this view? The emphasis is often, and this is a good point, right? The emphasis is often on the baby and not on the mom, giving attention to the baby, not giving attention to the mother. How do we go about changing that perception, and recognizing also that there are asymptomatic conditions, right? You normally don't look at someone and say, oh, you have hypertension. And by the time you know it, by the time their feet are swollen or their hands are swollen, they're pretty far along. So how do we encourage communities and pregnant mothers to recognize that they need to take better care, and get their clinicians to take more of a Sherlock Holmes approach on being curious about the care and the needs of their patients? What do you guys think about that?
Well, I can't answer that from a clinician point of view, but I think there are programs like the CDC Hear Her campaign, which does give you a lot of that information. But I think what that brings to mind for me is when Black women present at a clinician, it seems like there's this inherent belief by their provider that Black women can stand more pain, or they don't feel as much as white women, etc. So it's like, okay, well, you're saying you are having pain, but I don't believe it's really, that bad, kind of thing. And I know, for one thing, when I read some of my daughter's medical records after we lost her, I noticed that there were a couple of notations in there that she had poor pain management. Now she's coming in and has been paid 3 weeks, and yet and still that wasn't a clue that she was in desperate need of care. That was just to the practitioner that, oh, well, she may need a pill or something to help her deal with it a little bit better, kind of thing. And so that's something that has to be addressed as well, how Black women are perceived, because historically they could just take all kinds of pain. But, we're women. We're just like any other woman.
Yeah, I think that's an excellent point. And there have been a lot of studies that have shown that women in general, in particular women of color, the seriousness with which pain, comments about pain are taken is much lower than, for men, or for, really in any other condition. And I think that's where, going back to the biased blind software, now we're not there yet, right? But there is an idea that, as we're able to monitor mom's health better through objective measurements, what is the data saying? That will enable us to identify issues a little bit earlier. So to flag, you may not, because you're overworked, you've got too much going on, you may not be perceiving what's going on here, but here's a flag that there may be something off, that you may be missing, and that have that information, another set of eyes, in a sense, on the situation that is objective because it's based on data. That there's the hope there that technology can influence. But of course, it's still early days.
Veronica, do you think if that had been in place when Shalon came in, presented, would that have made a difference? I mean, she was telling them everything that this algorithm would have told them. And even if they saw that, would that have made a difference? Because in my mind, it would still be, she presents as a Black woman, and none of that makes a difference.
Yeah, and I think it's the $1 million question, and it's a really important question. And I think that, what we do know is sometimes, depending on who a patient sees, they may not feel comfortable escalating the question. They may have a doubt, but they may say, do I want to take this to someone else for a second opinion? If it's a nurse, for example, do I want to bother, the clinician that I'm working with this topic? And one of our hypotheses, and I think there's more data on this, every day, is that there is a role that technology can play in saying, hey, nurse, you can now bring this objective assessment with you so that you don't feel concerned that when you raise this topic to your, next level up, that you're not going to be taken seriously. So I think there's more factors that are, a lot of them are human-based, that are in there. I think that, again, technology can be an additional tool. I don't know, I wish I would know, and I wish it were possible to have that technology for your daughter, but I think that it could it have played a role? Possibly. Yeah, I think it's possible. Had that existed at that time and been part of the standard clinical practice, it could have. But Dr. Rick, maybe you have another perspective on that.
I think if it was, it's hard to know for sure, but with the programs, at least that I've used thus far, I think a warning sign, there's been a number of times I've brought patients in for blood pressure medications, IV hypertensives, even echocardiograms based on their vital signs. And I think that certainly technology could play a role in that. It's hard to not know the exact clinical situation, but it's what I've had. There's the ability to adjust medications and make sure they get the right treatment at the right time with more granularity than you get with, I'll see her back in a week. I know for my patients, especially in the postpartum period, has saved them readmissions, hospital visits, and I'd like to think adverse outcomes, but I don't know. That technology has the ability to flag things before they're critical, but there's also making sure that we have the right follow-up and listening to the patients when they call and say something's wrong. And I think hearing your story, ma'am, that's what bothered me most about what you said, is that they didn't listen. And there's studies out that show that Black women get unequal amounts of pain medication for the same pain scores on discharge after cesarean delivery. And that is something that needs to be acknowledged and actively addressed, and that it's maybe not a quick system, but actively being aware of that is a big step too, because when patients call with changes, and what we tell our patients is every day should be better than last. If you don't feel so good one day, you're in my office. And that really is a big part of the bottom line, is not just technology, it's addressing it.
Yeah, just want to add one. Wanda, sorry, did you want to say something?
No, I was just going to say you're absolutely right. And you mentioned something about not presenting itself. And even if you do, there's still that problem of getting someone to believe you. And as far as escalating, I wanted to do that. And my daughter said, oh, Mom, don't, because they're just going to see you as an angry Black woman, and it's just going to make matters worse. So it's like a vicious cycle, being a pregnant or a mother who's just delivered and being Black. The two just don't coexist.
Yeah.
especially.
I just want to reinforce that. I mean, even so, I had 2 high-risk pregnancies and, work in the, the med tech field. And even so, being a, postpartum woman, you never have felt as vulnerable as in that moment. And it feels impossible to be heard. And I think that, at least for me, that's part of what makes me so passionate about this change that we're all trying to drive. Is there is a problem there, and there is no simple answer. I mean, for the poor OBGYN clinicians that have an exploding number of cases and a stable number of clinicians in the field, it's also something that's difficult for them to tackle. And I don't think that any OBGYN got into the field to not see those things. So it's just an incredibly complex issue, but I think this raising awareness of the problem and putting in place things like reimbursement and data gathering to really confirm the underlying causes and to act on them is the right path forward.
All excellent. Go ahead, Ms. Irving.
Excited about at Dr. Shalon's map is the new app, because that will provide a peer support community for women. And they can talk to people who've already walked a mile in their shoes and said, okay, I've had the same problem. This is what you really need to do. In addition, we're working on a 911 kind of button on an app. So if you're having this kind of dialogue with a practitioner who's not believing you or is not listening to you or is dismissing you, if you push the button, then that will escalate it into our arena, and we can help advocate for you. So I think digital technology has come a long way and will continue to go a long way toward helping solve this maternal mortality issue.
I think that's a really brilliant solution, and we're looking forward to following you and learning more about it and sharing the word. And it most certainly will help many women. One of the most surprising, perhaps, cases, the most unexpected person, I believe is the name of the article, the most unexpected, the last person you would expect to die during childbirth. The story of Lauren Bloomberg, who in 2017, right? She was a NICU nurse, gave birth in the same hospital where she was actually an employee, and several times over had say, hey, I'm having a problem. And, the staff not testing her, but it's the very last minute. And unfortunately, she had a cerebral hemorrhage and passed away. So clearly, we only have time for one more question. And I want to leave that question, if you don't mind, ladies, with Ms. Wu. If you could, Tanya, share with us, what do you see as being some of the future policy changes that we should be really looking forward to and considering that may not be actually proposed at the moment, but that should be on everyone's radar?
Yeah, no, thanks for the question. I think, with anything that we do up here when it comes to federal investments or policy changes or new programs, I think it's, and to build off just where the conversation has been with this panel, it's just nothing that we invest in or that we develop, it occurs in a vacuum. So I think, especially when it comes to bias and disparities and addressing structural racism, I think to be cognizant of that and to be proactive about that is definitely a priority, and it should be. And it's not just assuming that if we were to create a new technology, it's a great tool and it's definitely an avenue for improvement for any avenue of care. I think being conscious of just how providers and patients are able to incorporate that within the system that we currently live in is one piece. And I think the policymaking moving forward is just being conscious of that and just realizing that perspective is definitely a big thing. And I think just speaking, if there's specific policies or programs looking forward, what I've been hearing a lot of is, technology is definitely a big piece, especially with telehealth after, how the pandemic has influenced how we access care nowadays. But I think there's also a bigger conversation when it comes to access and to affordable coverage in insurance, because, it's great to have all these tools, but if you can't afford it, or if a mom can't access it, it limits the ability, it limits the good that it can do. So I know that there is a very big effort up here to extend Medicaid coverage 1 year postpartum. I know that's a big push up here as well, because, like y'all said in the statistics, a lot of times, mothers who have issues, a lot of times it's after birth. And so I'm trying to expand that coverage, trying to expand just making sure care is accessible and to meet populations where they are, making sure that providers are able to, know these populations, making sure we're investing in providers who are willing to go into these avenues of care is another thing that I've noticed people are pushing for. And I think other things that people are also looking at is also just how, our health systems, how we fund our health systems and how we direct funding to specific, benefits or specific, resources within a health system, and how maybe we need to better tailor that to vulnerable populations that have been underserved historically. And, if there's changes that, we got to meet populations where they are and recognize the demands where they are and be cognizant of that is, I think, the direction that at the federal level and definitely in a lot of states that's hopefully is where the conversation is going.
Well, ladies, this has been an incredible conversation, acknowledging where their best practice comes into clinics in terms of listening to patients as being a best practice and leveraging the technology and having patience with both the patients themselves and also acknowledging that the use of technology on its own is not enough, that it needs to be balanced with the needs of communities, and that we also need to acknowledge that there are challenges, whether it's biases, inherent biases, or racism that need to be overcome, and that there's great opportunity that presents when we also use our voice to vote and encourage our representatives to bring these issues forward in Congress. So I want to thank you all for your time today on the panel. I'm going to now hand it back over to David.
Thank you so much to both the panelists as well as the attendees for really making that such a vibrant conversation, not only live, but also in the chat box and the Q&A. Before we wrapped up, I just wanted to take a quick second to plug the HIMSS Global Maternal Health Tech Challenge. The Tech Challenge seeks to save mothers' lives across the globe by crowdsourcing solutions to address barriers in care coordination and behavioral health that can be implemented to improve maternal health outcomes. You can learn more by reaching out to me or by visiting the website www.hims.org/GMHTC, which stands for the Global Maternal Health Tech Challenge. And that brings us to the end of our program. Thank you to everyone who stuck around until the end. Thank you again to all our panelists and Fran for doing such a great job moderating. To learn more about the Match Coalition, please visit the website, matchcoalition.us. And if you have any questions, please reach out to Daniel Montez at the email on the slides. Thank you so much, everyone, and enjoy the rest of your day and the rest of your week.